Hello, I'm going to talk about non-invasive cardiac radiation for ablation of ventricular tachycardia. Definition: one such technique is stereotactic body radiation therapy (SBRT), which delivers precise, high-dose radiation to targets in the body with minimal damage to normal adventitious tissue. This therapy has resulted in eliminating chordal fibrosis and electrically inert tissue with evidence of acute or subacute injury to nerve tissues during 6 months of follow-up.
Depending on activity level, the heart beats about 60 to 100 times per minute. It may be higher during exercise or lower at rest. A normal heart rate and rhythm ensures the delivery of oxygen-rich blood to all of the body's organs, such as the brain and lungs. A group of cells in the heart, called the cardiac conduction system, uses electrical impulses to control the speed and rhythm of each heartbeat. An abnormal heart rate or rhythm, called an arrhythmia, occurs when there's a problem with the heart's conduction system. Tachycardia is a type of arrhythmia where the heart beats too fast. Fibrillation is a type of arrhythmia where the heart beats irregularly and may be too fast. For certain types of arrhythmias, a catheter ablation procedure may be necessary to stop the heart tissue from causing the arrhythmia. After numbing a small area in the groin with a needle, the doctor will insert a short hollow tube called a catheter sheath into the femoral vein. Next, a long, flexible tube called a catheter will be inserted through the sheath. The doctor will guide the catheter to the heart through a blood vessel that goes to the heart, called the inferior vena cava. The location and progress of the catheter will be monitored. When the catheter reaches the heart, the doctor will guide it to the area that is causing the arrhythmia. The doctor will find the problem areas using a 3D map of the electrical activity of the patient's heart. The tip of the catheter will emit either hot energy or cold energy to ablate the tissue in this area. Ablation makes the treated area stop working. For an atrial arrhythmia, a doctor will ablate the atrial tissue causing it. If the affected tissues are small, well-defined areas, the procedure is called focal ablation. Or if the affected tissues are larger areas with more complex rhythm disturbances, the doctor may perform a procedure called ablation remodeling. Both types of ablation restore normal electrical impulses and prevent an arrhythmia from happening. If the cause of the arrhythmia is in the ventricle, the doctor can do either focal ablation or ablation remodeling to treat more complex arrhythmias of the ventricle.
Applications in medicine. Non-invasive ablation of cardiac tissue to control ventricular tachycardia or VT is a novel therapeutic consideration in the management of ventricular arrhythmias associated with structural heart disease. The technique involves the use of stereotactic radiotherapy delivered to VT structures or substrates.
Today we're here at California Pacific Medical Center, which is in San Francisco. This is one of our dedicated electrophysiology labs where we're very fortunate to have cutting-edge technology that allows us to perform complex catheter ablation procedures such as ventricular Ventricular tachycardia ablation is all about finding the spot or the short circuit that is causing the rhythm disturbance. And using catheter-based technology, we find and eliminate the cause. Here at California Pacific Medical Center, we have our anesthesiologists sedate our patients very comfortably with the non-sedated procedure. And through a small incision that I make at the groin site, I place sheaths into the veins, and you can see me putting in catheters here. Then we push soft insulated wires or catheters through the large central veins, and you can see the catheters now floating up through the inferior vena cava. And we can also utilize the stereotaxis remote navigation system to move catheters inside of the heart. There are several advantages of using this newer system. One of them is the catheters are very soft. You can see me pushing the catheter now up against my hand, and it buckles very easily. This virtually eliminates the risk of catheters causing any unwanted injury to the heart wall. Also, in addition to this, using these large earth magnets that are housed in these retractable towers, and in this image you can see the towers being pulled in on either side of the patient. The magnets then move the magnetized catheter with millimeter precision to really all corners of the heart just through computerized controls. And you can see us now dragging the L icon on the screen and moving the catheter in this way. In a very controlled environment, we start up and stop the ventricular tachycardia using pacing and intravenous medications, and we start visualizing where the tachycardia is actually coming from. Here is a reconstructed 3D virtual image of the inside of the right ventricle and the patient with ventricular tachycardia. The earliest electrical activation is seen here on this map and shown by red. So let me explain catheter ablation in a little more detail. If this here, my hand, is the wall of the heart, the ablation itself is caused when the tissue underneath the tip of the platinum catheter electrode is heated to somewhere between 50 to 60 degrees Celsius. Now this in and of itself is not very hot, but when kept on one spot long enough, somewhere between 30 to 60 seconds at a time, that's enough to cause some denaturing right below the tip of the catheter itself. And this denatured tissue stops all electrical conduction. And over a few months' time, this denatured tissue then heals itself into some permanent scar. And this is what keeps ventricular tachycardia from reoccurring. So in summary, catheter ablation for the treatment of ventricular tachycardia is a procedure that really relies on us being able to precisely localize where the site of tachycardia is actually coming from. It is through real advances in technology that we've been able to now perform this procedure not only effectively, but safely, such as the use of 3D imaging, where we're able to visualize where that spot is actually coming from, or the use of magnetic remote navigation, where we're able to move catheters safely as well as precisely within the ventricle. Catheter ablation is an emerging tool in the treatment of ventricular tachycardia, and alongside other therapies such as medications or implantable cardioverter defibrillators, it should be a treatment that is considered any time we're dealing with ventricular tachycardia.
Next, we're talking about pros and cons. Invasive mapping can be used to identify a target. The use of non-invasive ECG and imaging techniques combined with multi-electrode body surface ECG recordings offers the potential of a completely non-invasive approach. Early case series have demonstrated a consistent decrease in VT burden and sufficient early safety to allow more detailed multi-center studies.
Here is a question for you. What determines VT recurrence in patients who undergo ventricular tachycardia ablation for post-infarction VT? Now and Jack, researchers try to answer that question. They performed catheter ablation in 98 consecutive patients with post-infarct VT. The electrograms from the implantable cardiac defibrillator were then analyzed, and VTs were classified as being clinical, non-clinical, or clinical. So, who has recurrent VT, and where does the VT come from? Patients with recurrent VT have a larger scar area as assessed by electroanatomic mapping compared to patients without recurrent VT. In patients with repeat procedures, the majority of distal VTs for which a crucial area could be identified were at a distance of about 6 millimeters from prior ablation lesions. What's the answer to the question of what causes recurrence of VT after ablation? Patients with recurrent VTs have a larger scar, most recurrent VTs are new, and the majority of these VTs were mapped to the vicinity of prior ablation lesions in patients with repeated procedures. I'm Peter Bach, and this is a Cardiac Source.
Let's jump home. Catholic Regional Medical Center.
Thank you, Today I'm going to take a new medical specialty is available full-time in the Tri-Cities. It's called electrophysiology cardiology. Joining us this morning is ED specialist Dr. James Keller. Dr. Keller qualifies for what we call an ablation procedure for folks suffering from atrial fibrillation. Right, so we offer ablation procedures for atrial fibrillation to patients who are sufficiently symptomatic, meaning this condition is really actively bothering them in their daily lives, and we usually ask them to try at least one antiarrhythmic medication to control the AFib prior to offering the ablation procedure. Is an ablation. So an ablation is quite a sophisticated procedure. Takes us 4 to 6 hours to complete a cath lab. Going into your heart with catheters, entering through the veins in your groin. We thread the catheters up in your heart, the catheters are then tubes up spaghetti, follow the blood supply very naturally into your heart, and we position those in the heart to measure atrial fibrillation and identify sites in the atria which are supporting that rhythm. With one of those catheters, we can apply current, which is heat energy, to disrupt the electrical function of that part of the chamber with the goal of eliminating atrial fibrillation. So a fairly long procedure, pretty effective it sounds. Can be very effective. Results continues, even surprisingly, for some patients. Excellent. Well, if you'd like to connect with Dr. Keller, you can give his office a call at area code 509-942-3272. Our thanks to Dr. Keller, and thank you for watching 2 Minutes.
Next, we're talking about issues in Ecuador. Non-invasive ablation of cardiac arrhythmias using standard synthetic ablation devices has been reported, offering process targeted of myocardial ablation sites not invasively with 4D imaging of anatomic targets using cardiac-specific planning and tracking software. With minimal radiation exposure, it's outside of the treatment target. The procedure is painless and doesn't require anesthesia. A variety of radiosurgery platforms can be used.
I've always been interested in the heart since high school, and for some reason I got drawn into transplantation. To give back a lot to the patients that I take care of. And heart transplantation is one of those things that is the ultimate where they give back to someone, their life, their family, and themselves. It's not so much that the patient comes in, gets surgery, and is forgotten. from the moment that the patient, I see the patient, and the patient becomes part of the entire team that we have here at the clinic. They become like family. We know everything about the patients, try to understand what their issues are, what the problems are, and it becomes a journey, because heart failure is a chronic condition. There's been patients where, I transplanted perhaps mother or father, and their child is with the same problem. And again, because of the way that we really develop a relationship with the patients, they always come back to us because we have that really deep relationship with them. These are very complex questions in terms of when is the patient ready to be transplanted. There are times that patients are very anxious and they want to get transplanted, and I can understand the emotions that they may be going through. We've had enough experience to know when we need to wait a little bit longer to perhaps get that perfect heart for them, even if they're anxious in terms of the fact that they want to move forward. How do I change as a physician? I think I've become wiser, and there's no question that experience counts a lot in this field. I'm very different from when I finished my training. I've remained passionate as I did when I finished my training, but now I have the 15 years of experience behind me. That's very difficult to learn in any textbook or from any something that you need to personally experience, and that's probably one of the biggest assets I have. I always tell my fellow residents that we can teach anybody to sew, but it's the judgment which comes with experience that differentiates an excellent outcome from others. So that's what's.
And last but not least, conclusion. Despite its limitations, non-invasive stereotactic heart ablation has undoubtedly extended to the therapeutic auditory ventricular arrhythmias and clearly warrants further investigation. It goes to the ventricular until safety and efficacy can be established in larger trials. There should be cautious optimism. Thank you.